Okay, I think I'll go ahead and get things started, and I'm sure people will continue joining in the next couple of minutes, but we'll try to respect everyone's time and just launch things off here. So welcome to our annual Fall Implementation Science Seminar Series. My name is Dr. Alethea DeRogers, and I am an associate professor in the Department of Psychiatry and Human Behavior at Brown University, and I'll be hosting the Fall Seminar Series. This is now the 8th year of our Bridge program's implementation science programming, and we are thrilled to bring these seminars to our Providence, Rhode Island community of implementation scientists, as well as those of you who are joining us from other regions. We are grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or Advanced CTR, for supporting the technology, logistics, and marketing of these seminars. We also recognize our partnership with the Brown Alcohol Research Center on HIV for their support. I'm really excited to announce and welcome our speaker for today, who is one of our Bridge faculty members here at Brown, Dr. Greg Rosen. He is an assistant professor of medicine and epidemiology at Brown University, and he's also a research scientist in the Division of General Internal Medicine at Rhode Island Hospital. Greg leads and contributes to research at the intersection of HIV treatment and prevention and substance use services globally. His research broadly harnesses health workforce capacity enhancement strategies and health system reconfigurations to optimize delivery of HIV and harm reduction services to marginalized populations, with attention to mobile and transient populations like sex workers or people who use drugs in sub-Saharan Africa and also in the United States. The title of Dr. Rosen's presentation today is Choice-Based Conjoint Methods to Identify Implementation Priorities and Strategy Preferences to Guide HIV and Substance Use Service Delivery. As a reminder, you can put your questions in the chat function throughout the seminar, and we'll have 10 to 15 minutes at the end of today to have some questions and answering and discussion. So thank you so much again, Dr. Rosen, and I will turn it over to you now.
Fantastic. Thank you, Dr. DeRogers. And just wanted to confirm that the screen sharing still seems to be working and you can hear me okay.
Looks good to me.
Perfect. Fantastic. Well, thank you all for being here. I hope folks who are joining today were not especially excited to hear the original talk, which had an addendum of human-centered design. I do have some slides in here that are going to be devoted to synergies between choice-based conjoint methods and also human-centered design. So please do stick around because you will be getting some of that content. At next week, I believe it's next week's seminar, you'll be hearing an entire hour of human-centered design approaches. So I changed things up in the final hour and decided to focus entirely on choice-based conjoint methods, which I think are very exciting and are certainly growing exponentially in public health research and scholarship. So I'm excited for the opportunity to give this talk and to share what I've learned from using some of these methods in my own work and work of my collaborators, and really looking forward to not just the presentation, but also the discussion of how you might be able to use some of these methods in your own work. So I'm excited to be here and share just a little bit about some of my own work at the intersection of HIV and substance use delivery and thinking through applying some of these methods to help us think through implementation priorities and guiding identification of strategies in the field of implementation science. So these are my disclosures quickly. For today, what I'm hoping we can do is think through distinguishing between choice-based conjoint methods, which I'm going to be referring to as CBC moving forward for short, and other types of preference elicitation approaches you might be familiar with. I'm also hoping to explain what the utility of CBC methods are in the implementation science research and why these can be valuable tools to add to your toolbox of existing research methods. I'm then hoping we can do a deeper dive into some case studies of applications of CBC methods to address implementation problems in the context of research that I've been leading and supporting, both internationally and domestically. So you'll get a nice flavor of both global health as well as domestic health examples. And then lastly, to identify some synergies between human-centered design and CBC methods. So I'm not completely leaving out any attention to human-centered design, which is also a major component of a lot of the work that I do. So let's dive in and talk about what choice-based conjoint methods are. So really, when we talk about choice-based conjoint or CBC methods, we're talking about methods for learning about individuals' preferences for specific combinations of features that constitute a specific product or service. So much of this really derives from behavioral economics and marketing research, language and literature, but it has really nice applications in public health research and scholarship. This is CBC methods are also distinguished from other types of what we would generally call conjoint methods because they've actually forced the expression of choices from a set of concepts rather than forcing people to just simply rank or rate preferences. So instead of thinking through me sort of giving an itemized list, of, let's say, groceries that you might want to buy at the grocery store today, and have you rank them in terms of preferences for flavor or for what those might cost. I'm actually forcing you to make a choice that either reveals your alignment with specific components of an entire service or product. And so I may force you to choose between different sets of features that are related to taste, price, and other things. So in other words, when we talk about CBC methods compared to just general conjoint methods, we really are in the field of choice making. And then lastly, as I mentioned before, this is work that is rooted in market research and economic modeling, but has broad utility in other spaces and scientific disciplines. And really, I think to emphasize this point, in PubMed a couple of days ago, I had quickly searched the words discrete choice experiments, and you can see that in the bottom left, you'll see that there really has been what I would describe an exponential growth in publications over the last 2 decades that are using CBC methods like discrete choice experiments or DCEs in this space. So clearly, there are not only unique applications of this work in public health and implementation research, but there's also entire systematic reviews and scoping reviews that are dedicated to the application of these methods in very narrow areas, as I've displayed here on the map and with the screenshot that I've provided of one such review. So we've now talked a little bit about choice-based conjoint methods. One of the most popular forms of a choice-based conjoint method exercise is called the discrete choice experiment, or a DCE. This is really going to be the focus of a lot of today's presentation since it's one of the most popular applications of CBC methods. And what we mean by DCEs are methods for quantifying the valence, so the direction, the magnitude or the strength, and heterogeneity of preferences for specific product or service features. So a very simple example I could give about how you might want to conceptualize a DCE is if you are someone who's looking to buy a new car, you might want to be looking at different features of a car that will drive your preferences. So, for example, the color of the car, the make and model, preferably, potentially, the price points that are being offered. So those are different features. What I might do in a DCE is randomize those different features to you and force you to make different choices that will essentially reveal what specific features or items drive your preferences. So another way we could think about this when applied to public health is thinking about, for instance, in a lot of the work that I do, which is in the space of HIV, thinking about preferences for different HIV prevention product features, like pre-exposure prophylaxis. So here you'll see an example of a large discrete choice experiment that was administered in Latin America, where they asked folks to select between different randomized features of PrEP products. And so in what you're seeing here is a literal screenshot of a discrete choice experiment task, where participants are forced to choose between two different products that were generated from simulated features. And so on the left is product A, and on the right is product B. And so what you can see as part of a DCE in practice is that you are forced to make choices about a complete product or service, or in this case, a prep formulation, based on the individual items that are shown below the product titles that describe the specific characteristics of that product. So there are a number of reasons that you could conduct a DCE, and I would say that in the words of Mick Jagger, for any Rolling Stone fans out there, is that oftentimes we in public health can't design everything for everyone. And so what we have to do is think about what is going to give us the most bang for our buck. We do not operate in a world of unlimited resources. And so we have to think very intentionally about what it is that may drive someone to either uptake a product or a service, or alternatively, what things may be more impartial to individuals. So what are things that people actually in practice don't really care about? And then lastly, what are things that may drive people away from our products and services? And so these are all reasons to think about using discrete choice experiments and other DCEs in the public health landscape. And so in an ideal world, we're going to have the best of everything: clothes, food, travel opportunities, access to retirement funds. But the reality is that we oftentimes have to make choices or trade-offs that reflect our priorities and help us maximize utility of the things that we are choosing. And this is oftentimes a product of resource constraints. And so in this kind of resource-constrained environment, we have to prioritize specific aspects of a product or service to make available to people. And while this is true in our own personal and private lives, this is also very much true more publicly in the fields of healthcare and implementation science. And so by doing a discrete choice experiment, what it is that we're hoping to learn are identifying which attributes of a specific product or service matter most to people. So whether they're favored or disfavored or folks are impartial to them, they also help us quantify features of a given attribute that are most appealing or unappealing to participants. And lastly, they help us understand trade-offs to maximize end user satisfaction, uptake, and continuation in the context of these resource constraints. So I've been using a lot of terminology, admittedly, as part of this presentation. And so just so we are all sort of aligned with a shared vocabulary, when I use the term attribute in a DCE, I'm referring to sort of the specific characteristics of a product or service. And so these could be things like color of a car, the manufacturer of a car, the price of the car. When I'm using the term level or item, what I'm referring to are these are the distinguishing components or features that are nested within attributes. So as an example for color of a car, so color again is an attribute, different levels or items of that would be red, blue, black, or white. In a DCE, we also use terminology like choice tasks and choice sets. And so a choice task would really refers to the simulated scenarios of combinations of attributes and levels. And oftentimes in a discrete choice experiment, we're doing anywhere from about 8 to 12 choice tasks per participant. For a choice set, these are the unique combinations of simulated choice tasks. And we'll describe why it is that oftentimes in a discrete choice experiment, we're working with more than one choice set. So you may be asking yourself, I don't really understand, or it's not really clear to me what is an experiment or what is experimental about a DCE. And so what I would say is that these are in fact experimental, because if you think about all the different combinations of attributes and levels that you might have in a discrete choice experiment, there are many, many different types and sometimes an unlimited amount of profiles for different products or services that you may present to individuals. And it's not really possible to ask every single person every single combination of these attributes and levels. And so what we have to do is use different types of randomization strategies in our surveys to essentially maximize the design efficiency of these experiments such that not all participants receive the same exact questions. And this is why the word experiment is really important when we're talking about discrete choice experiments, is because not everyone typically is answering or responding to the same types of questions in the exact same way. And more importantly, they're randomized. There's some level of randomization to the types of combined attributes and levels that they are getting. So you might also be asking yourself, this sounds really great. Is it too good to be true? And I will say that yes, oftentimes DCEs sound very appealing and exciting when you first learn about them, but there are some really important limitations with discrete choice experiments as well as other kinds of CBC methods. So the first is really that this is cognitively burdensome for participants. If you think about having to choose between 2 or 3 products 10 to 12 different times, you might get exhausted thinking through what it is specifically about each of those products you're randomized to that is most appealing or interesting to you. There's also this phenomenon in discrete choice experiments called anchoring bias, which is that the order in which specific components or levels are presented drive the preferences. And so what I mean by that is that if you have an experiment where you have 5 or 6 different attributes, oftentimes you're going to have participants that frequently are only going to be reading the first 2 or 3, especially or paying attention to those first 2 or 3, especially in situations where they are either completing the survey on their own or it's an entirely self-administered process. And so anchoring biases are really something that we have to think about and account for as part of, as an inherent limitation of this work. The other reality that we have to contend with the discrete choice experiment is that people's stated preferences don't always match their revealed preferences. And so what I mean by that is that we can ask people hypothetically which of 2 or 3 products or services they might prefer, and those will reveal specific insights about what components of a service we may want to make available. That doesn't always align to or doesn't predict whether people will actually uptake or use those services if offered in reality. And so something that we have to always contend with in this world of choice-based conjoint is that oftentimes we are asking people about hypothetical preferences, and it's not a reflection or a prediction of their actual reality or behavior. So I'm going to now switch gears a little bit and talk about a little more specifically why we may want to consider using some of these methods in the field of implementation science. And so I always say it is possible to use these in implementation science. And let's refer to this implementation science outcomes taxonomy that was developed by Enola Proctor and colleagues. So in the field of implementation science, we are particularly interested in implementation strategies. And so there is some level of distinction between what we would consider evidence-based practices or interventions and the strategies that help deliverers make those products and services available. So it's easy to conceptualize using a discrete choice experiment if we're doing intervention-based work. But in the field of implementation science, when we're talking about implementation strategies, I would also argue that in some cases, those strategies are products or services that we can elicit preferences about. And so here is just an example of how discrete choice experiments are gaining a lot of popularity in the implementation science space. And as you can see from this systematic review, there are quite a bit of published discrete choice experiments across different disciplines. So there are examples of scholars and researchers and practitioners that are using this method successfully to understand and characterize implementation strategies that maybe are the focus of their research in different domains. And so when we think about what it is that we may want to specifically elicit in a discrete choice experiment with respect to implementation strategies, I've put up here some more work from Enola Proctor and colleagues that really provides, I think, a nice blueprint for the different things we want to specify about implementation strategies. So in this taxonomy of actor, action, temporality, dose, justification. All of these things you could think about as potential attributes that you may want to ask about in a discrete choice experiment for a specific implementation strategy. Something that I also want to make note of here is this tension between implementation strategies and what other people have called adjunctive interventions. And so I'm not going to get too much into the details and the nitty-gritty of this, but the way that I think of trying to sort of distinguish between whether what we're doing is really implementation science is to think about where there where these sorts of interventions and practices and strategies are focused. So oftentimes in implementation science, strategies are really focused on the deliverer or people that are practicing something like an evidence-based practice or intervention that improve that avail or make better an intervention, an existing evidence-based intervention. When we talk about adjunctive interventions, these are things that help people or it's conceptualized that these are things that help end users better engage or participate in receiving evidence-based interventions or practices. So we could think about things like digital applications, like mobile health apps as being an intervention, as an adjunctive intervention. Whereas when we think about implementation strategies, we could think about such things like workflow modifications. Obviously, those will have to be a lot more specified, but these are the types of things that may help us think through whether something we're talking about is an adjunctive intervention or whether it's more an implementation strategy. Ultimately, I think jargon aside, what really is important with discrete choice experiments in this field of implementation science is that what we want to elicit as part of preferences should really be focused on change methods. And so whether we end up talking about adjunctive interventions or implementation strategies, what we want to be eliciting as part of our work is something that is going to change the dynamics or the setting or the experience of users that are interfacing with evidence-based practices or interventions. And so, folks, you all have been waiting very patiently to hear about how we actually might use some of these methods in practice. And so I'm going to begin by talking about an example of a discrete choice experiment we conducted in Chicago through the Neighborhoods and Networks cohort study, where we sought to try to understand participants' preferences for different alcohol cessation support services and service delivery strategies. And so the Neighborhoods and Network Phase 2, or N2P2 cohort, is really focused on understanding the syndemics of cannabis use and co-occurring substance use disorders and sleep health with HIV prevention and care outcomes. It's a cohort of about 600 young Black men who have sex with men that were recruited in the Chicago metropolitan area and are followed over an 18-month period. And so during some of the initial work in N2P2, we found that there was quite a bit, in addition to all the other substance use we were looking at, there was quite a bit of hazardous alcohol use that was reported in the study population. And this graphic here summarizes some of the findings from a cross-sectional analysis where we looked at correlates of heavy alcohol use as measured by the audit C and looked at what things factor in or what things are associated with heavier alcohol use. And so this really provided, I think, a foundation to do some additional work within the N2P2 study to look at people's experiences with outpatient alcohol treatment, if any, as well as what their preferences may be to receive alcohol cessation support services. And so we began by doing some journey mapping work with a set of participants who were exhibiting heavy alcohol use to understand what their preferences broadly for specific services might be and their types of experiences receiving screening and brief interventions for alcohol use disorder. And what we learned is that people really did not have a lot of exposure or experience to these types of services, even though they sort of expressed a really strong desire to reduce their alcohol use. So we identified that there was really a high desire for these types of services to be availed, but there were little opportunities in which participants knew about or could engage in these types of services in their existing service delivery ecosystems. And so this led us to design a discrete choice experiment, which was nested within one of the rounds. So it was done cross-sectionally in this cohort study. As with the other procedures of the cohort, this part of the survey is entirely self-administered. So participants were able to complete the discrete choice experiment on their own without an enumerator or survey administrator. This specific discrete choice experiment included of 10 different tasks, and it had 3 attributes with 3 to 4 levels each. The image that you see projected here shows an example of one of the choice tasks, one of the 10 choice tasks, where participants were asked to rank or select their single preferred service delivery bundle of alcohol cessation support interventions based on these 3 different attributes. So these 3 attributes are service modality, so what it is that participants are getting, frequency of delivery, or how frequently they're getting it, and then the setting of implementation. So at what venue where would participants be receiving these types of services? So in this specific exercise, to maximize the design efficiency, we ended up having participants choose between 3 different bundles of services. Most of the time in a discrete choice experiment, you're working with just 2 different bundles at a time. But in this specific example, we worked with 3. And then participants could also tell us, as you see at the bottom of the screen, actually, I don't want to pick or select any of these options because I don't like any of them. And so once we processed this data with 157 participants who completed the discrete choice experiment, we found that service modality was actually the most important attribute that drove people's selections of bundles. So people cared most relative to the other attributes about what type of service it was that they were getting, whether it was pharmaceuticals, whether it was counseling, or something else. Frequency of delivery and implementation setting were less important, though, as you can see, they do factor into a substantial proportion of people's selections of preferences. And so here what I'm walking you through is fundamentally the quantitative output of a discrete choice experiment. And this is what really helps us understand and interpret data that is derived from a discrete choice experiment. So what you see in that second column on this table is what's called a preference weight. This is also in other economics, marketing literature is referred to as a part worth utility. And then on the third column, you'll see the confidence interval. So what is illustrated here are zero-centered part worth utilities. So the way that you would interpret these are both based on the valence, so whether the value is negative or positive, and then whether the value itself, the scale of the value, so as you'll see, they go from negative 100 to 100, whether these variables or these values overlap the null value of 0. And so the way that you might interpret some of these, for example, is that if we go to that first section of service modalities, we can see that individuals really had strong preferences for one-on-one counseling. So you can see here the preference weight being 25, the confidence interval does not overlap 0. But if we compare that to medication, like you see in red, individuals really had a strong aversion to medication, which is exhibited by the fact that the preference weight was close to negative 40, and this value also did not overlap the null value of 0. And so we could read through this table line by line using that kind of that type of interpretation. And what you'll end up seeing are some of the conclusions that we drew from this study, which is that the preferences people exhibited were really driven by the service modality and the frequency of delivery. The strongest preferences overall, as you can see, both from the previous table I showed you, as well as the relative importance scores, were for non-daily touch points with service delivery. And lastly, people really had strong preferences for in-home or virtual delivery or community-based delivery. Really, folks did not want any sort of alcohol cessation support services that would have to be based at a clinic. And so we can sort of take insights from all of these activities to think through how we might design either adjunctive support interventions or alternatively implementation strategies that better engage individuals with alcohol use disorders in cessation support services. And then, of course, there was a very, very strong preference for one-on-one counseling. So what I would say, in addition, is that if any of these services were to be offered as adjuncts to other existing interventions, the biggest bang for your buck will likely come from making one-on-one counseling available, especially when combined with other preferred service delivery features that participants expressed. So we're going to move over across the globe to South Africa to talk about a discrete choice experiment that we just finished in the context of a cross-sectional study of female sex workers who use opioids. So this work was done in two different districts in South Africa. The first district was eThekwini district, which is in southeast South Africa. You can see an image or picture of the city of Durban on the top left of the screen, which is part of eThekwini district. So this district is a little more urbanized compared to other districts in South Africa. It covers Durban and the surrounding metropolitan communities. We also we also recruited participants from another district called eThekwini district, which is in northeast South Africa near the Mozambique and Eswatini borders. And a picture of that is on the top right. It's a much more rural setting that covers a single peri-urban community and the surrounding rural communities. And these two districts were picked intentionally because the dynamics of the opioid and broader drug supply in these areas look very different. So, for example, the potency of opioids along the southern coast of South Africa, where a lot of major metropolitan areas are located, tends to be a lot stronger. Whereas as you go northward to more rural areas, the potency of illicit opioids tends to be weaker. And so what this oftentimes translates to is that there's a lot higher rates of injection drug use that are reported in the more rural areas relative to the urban areas in this population in South Africa. And so quickly, we did some other formative work to really identify patterns of substance use in a population of female sex workers predating this specific study. And what we saw is that oftentimes it's really the co-occurring use of opioids and stimulants that really is associated with the more adverse HIV treatment outcomes in this population. And it's not really just one specific drug that folks are using that may drive disengagement with HIV services or their inability to adhere to treatment, but it really is taking more of a polysubstance use approach or paradigm as we think about these kinds of issues. And so we conducted some in-depth interviews predating our discrete choice experiment with both sex workers in these two districts, as well as different implementers of HIV services, as well as folks who implement existing methadone services. And the goal of this work was really to understand what kinds of adaptations would be needed to the methadone service delivery architecture currently in South Africa to appeal or better engage sex workers. And so sex workers really, I should say also providers really described adaptations that operated at many different levels that would be required to engage them. So for example, making services more mobile, having clinic hours that accommodate their occupational schedules. So making clinics and weekends available at certain times for methadone dispensing. Having peers or other women really be leading some of the work in these methadone clinics because these clinics were oftentimes the clinics or spaces where methadone was being dispensed were frequently described as very male dominated spaces. And so a lot of women in our study essentially felt that these spaces did not reflect their needs or they were not accommodating to them, and they could at times feel very intimidating spaces for them to be in. And so this really led us to the design of our discrete choice experiment, where we sought to ask sex workers where, what types of locations they'd want to receive methadone, how frequently they would want dispensing to occur. So, is it something they wanted every day, or is it something they only wanted once a week in terms of, um, because methadone is taken daily, it would be the difference between having to be observed going someplace every day for a single dispensing dose versus having the option of self-dosing or self-administering at home and collecting medications only once a week. We also asked about the timing of service delivery, so um, whether they would want methadone to be dispensed in the morning, in the afternoon, in the evening hours. And then we also asked about other complementary services they would want to receive alongside their methadone. So, would they want methadone co-dispense with their HIV medications? Would they want to receive other primary healthcare services while waiting for methadone dispensing? Or would they want family planning and sexual reproductive health services in addition? So the graph that you see here, similar to the table I had shown you in the previous case study, again illustrates the preference weights for these individual features of methadone service delivery. And so what you can see here, I think, is that there are really, really strong preferences for having methadone dispensed via mobile vans, and then receiving take-home dosing, one and only having to go to the clinic once a week. So sex workers really wanted services that would meet them in the communities where they are, and also result in having to do fewer touch points with the healthcare system overall. They had really negative preferences, or they really disfavored having to go to existing methadone clinics, which we've described here as drop-in spaces or drop-in centers that had both men and women in those spaces, and they really did not want to have to go to a specific place or venue to receive methadone every day. For some of our other attributes, the levels within them did not really exhibit were not really strong drivers of a selection of a specific product. Though we did see some signals that sex workers really preferred dispensing in the morning hours, or methadone dispensing to happen in the morning hours, and had a slight preference for receiving HIV treatment services alongside their methadone. So we used a method called latent class analysis because what we suspected was that there was a lot of heterogeneity or variation in preferences. And what this method allowed us to do was to really identify hidden groups of sex workers within our study population who shared specific preferences that were distinct from one another in terms of the overall study population. So to walk you through the different lines that you see here, these each represent a discrete segment or class of sex worker based on shared preferences for a specific methadone service delivery feature. So as an example, the most prevalent or most common, largest, in other words, segment here is segment 4, which is represented by this red line that you see here. And the way that we would interpret this data is essentially we'd look and say this group that is represented in segment 4 has a really strong, in other words, positive preference for receiving methadone from a mobile van and receiving take-home dosing, but also preferring to receive methadone in the afternoon and evening hours. And now if we compare that, for instance, to segment 1, which is in this light gray line, you see that even though this was a much smaller fraction of all the sex workers in our study population, you'll see that this group, very, very different than group four, had strong preferences for receiving methadone in person. So they had a positive value for the preference weight for receiving methadone from either a female only or a mixed gender drop-in center. They wanted to go every day in person to receive methadone, so they had a strong preference for daily methadone dispensing. And they also had a slight preference for receiving HIV treatment services along with their methadone. So, in other words, even though, and I'll scroll back just so you can get a quick comparison, even though these are the overall or averaged or pooled preference weights from the experiment, this type of analytic method let us reveal that what we needed to see were that there are different people in our study population that exhibit heterogeneous preferences. And so making sure that services are agile and accommodate different people's needs are going to maximize utility of services. And so, what we learned from this DCE was that the most preferred service delivery features were mobile methadone delivery as well as take home dosing. Oftentimes, dispensing through existing methadone clinics that really um, were concentrated with clients or individuals that were mostly male and were people who were injecting drugs were might actually disincentivize methadone induction and continuation for this population. And then the preferences were also substantially heterogeneous. And so thinking through what types of individuals are going to benefit from specific combinations of services is really going to make sure that, as you know, especially in the context of limited funding in this environment for HIV and substance use service delivery in South Africa, that anyone who is offered methadone through a specific platform is going to be likely to access it if they can benefit from it. So I'll quickly describe some synergies between human-centered design and choice-based conjoint methods, since that was originally the subject of my talk, and I have really emphasized more so the CBC methods. So oftentimes, the way that I like to think about synergies between these complementary methodologies is the sequence in which they happen. So oftentimes when using human-centered design, we use those methods to ideate and generate specific ideas for products or services or strategies that then we can assess preferences of using methods like choice-based conjoint. Alternatively, we could use an approach where we're using choice-based conjoint methods to identify preferences for hypothetical services or interventions or strategies and use a human-centered design process at the end of that to help us refine and specify some of these prioritized strategies or interventions. So in other words, I think what I'm hoping to impart here is that these methods can be used together and in complementary fashion in either order. So human-centered design can precede choice-based conjoint or vice versa, but the goals of the design processes as well as the discrete choice experiment will vary depending on the starting point of your research. So hopefully I've gotten a lot of folks here excited about this kind of method in their work. And you may be asking yourself, is this something I should be using in my own work? And what I would respond is it really depends. So in research, and it's not just with this type of research, but I would say in all research, you want your research questions and objectives to drive the selection of methods and not really the other way around. So you don't want to just use CBC methods because you find them exciting. You want your questions and your research objectives to drive your decision to use these kinds of methods in your work. I will also say that these kinds of methods are really good ways to elicit preference about hypothetical interventions or services or strategies or products, but it's not going to be a prediction of how people make choices and behave in the real world. And so I always caution to say that, this kind of work is very analytically interesting and it's very intellectually engaging, but it's not going to predict what people actually do and how they behave and make choices if these hypothetical services were offered. So it's an initial window or an insight into people's behavior, but it's not an observation of people's actual behavior. And then lastly, I think that with choice-based conjoint and discrete choice experiment, these methods I think are especially powerful if they're coupled with other data collection approaches and methods, whether they're qualitative methods to guide or help narrow the type of services or products you're asking about in a discrete choice experiment, whether you're using human-centered design to refine or help continue reprioritizing some of the insights from your discrete choice experiment, or other types of methods that really offer complementary insights, given all the limitations that I've already discussed for these types of methods. So I'll just close by extending gratitude to the many collaborators and colleagues that I've had the privilege of working with on the two case studies I've presented with that were funded, which was research that was funded by NIDA and NIAAA. I like to say that implementation science and really all research is a team sport, so I think it's important for me to really thank them and the broader research teams for all their partnership and collaborations in this important work. I've put my email here in case folks want to reach out with any questions. Hopefully, I've gotten some folks excited about these types of methods in their own implementation science work. And I look forward to some discussion now. Thank you all for your time and for attending.
Thanks so much, Dr. Rosen. This was such a clear description, and I loved your case examples for how to use CBC methods. Really, really, really interesting stuff. So we have lots of questions coming in. If we have time, I might ask a few too, but I'm going to start with those of our attendees. So to start with, can DCEs be a step within a most research design? If so, could using a DCE as a way to inform optimization reduce the assessment of stated versus revealed preferences? Oh, you're on mute.
Sorry about that. Yes,
That's
that
okay.
is a great point. So if you are using a most, some kind of most design, um, you definitely can, use this to inform like subsequent randomization if you're using like an adaptive intervention design of some kind. Um, so I think there are different ways of integrating discrete choice experiments if you're using sort of the most suite of research. And there's different ways of doing that. You could think about doing it sort of before randomization to sort of identify stated preferences. And then you sort of, if you're offering some kind of choice-based trial, or that's your design where you have folks that are able to make decisions about what they are randomized to, um, you are able then to sort of compare stated preferences to revealed preferences. And the other thing I will say is that preferences are dynamic, they're not static. And so with a discrete choice experiment, we're oftentimes operating in the world of cross-sectional designs. And so that might be people's preferences at a single snapshot in time. And those are not going to look the same 6 months or a year down the road, and potentially after people have had the opportunity to experience a specific intervention or strategy.
Thanks. That's really an interesting point too about over time. I just have a quick follow-up. Do you ever kind of introduce another discrete choice experiment after a period of time and see if preferences have changed and perhaps potentially change what the intervention or implementation options are?
You certainly can. I haven't done that myself, and I don't think I've seen examples of this in the literature. I think one of the reasons that these methods, I think, have been thought of traditionally or really have evolved in terms of cross-sectional methods is because they're oftentimes used to think about hypothetical choices people will make. And so if you're using a discrete choice experiment, for instance, to help individuals to sort of identify what people may prefer, if people are now able to make choices in the real world, you don't necessarily need to re-administer a discrete choice experiment to identify their preferences. Rather, you can look or observe at how people are making actual choices, sort of in the real world or in a more controlled version of the real world if you're operating in a randomized trial, that I think sort of render the insights you might gain from a DCE somewhat futile. So I think oftentimes we want to do a discrete choice experiment to help us refine and think through what it is we might want to offer. Um, but people's choices, once those options are available to them, are going to be the most helpful guide in terms of how to continue adapting and customizing options that we make available.
Great. No, that makes a lot of sense. Another question is, how do you decide which choices to include in the experiment?
Yes, so that also a great question. Oftentimes these are going to be based on a priori, like whether you know of certain features that you're able to control. So oftentimes these might be things like prices, like can governments or can ministries of health subsidize the cost of certain things if they're available? I would say generally you want to be asking about things that are in the realm of reality, which is useful because it helps you sort of quantify trade-offs people are willing to make, especially when it comes to something being available for free versus not for free. Which is why I think a lot of these methods have gained popularity in sort of market research or behavioral economics. So the other thing that I always recommend doing is a lot of formative research, especially with qualitative methods, to sort of broadly unpack what people's preferences are related to whatever strategy or intervention it is that you are seeking to develop or adapt in your work. And so I think that leveraging robust formative research and also borrowing from the parameters of what you know you can intervene on, I think are a good way of helping to streamline the types of attributes and levels you want to articulate. I hope I understood that question, Alethea. I couldn't really tell if that question was focused on the choice, like the actual choice tasks people are viewing, or whether it was more about the attributes and levels that you design in your experiment.
I am not sure either, but I encourage the attendee to just add something else if not, if it wasn't.
Okay,
Looks like it was fine.
that was
It was,
Trisha. Okay, that was a
yeah,
good
I
that was a good answer. I will just say that the software in which you are designing discrete choice experiments, oftentimes they use a block factorial randomization to sort of randomize the attributes, the levels within each attribute, so your design is most optimally efficient for your sample size. So um, that's sort of how the choice tasks are created.
Great, great. Another question which a couple attendees have asked, and is also a question I had. Can you talk a little bit more about the sampling strategies for DCEs and how you might consider sampling to ensure generalizability?
Yes. So this, I would say this is always, and it's not just a tension, the tension here, but is also a tension more broadly in implementation science, where there's a tension between context and generalizability. So I will say that oftentimes when we think about a discrete choice experiment, our sampling strategy is most of the time informed by the design efficiency of the experiment. And so oftentimes what we end up getting in discrete choice experiments, especially in public health research, is not a very large sample. Um, I think that oftentimes what we want to think about is whether what it is that we are proposing to avail as part of a discrete choice experiment. So is it an intervention or is it a service? Is this something that is going to be available for a certain population of interest? Is that going to be upscaled? Or alternatively, is this something that we want to make available more at the population level? And I think that really fundamentally should be driving a lot of decisions that we are making in terms of sampling. for discrete choice experiments. And so if we wanted, for instance, a sampling strategy to help us get at a larger, more robust population level or population representative assessment, we could think about, even since a lot of these can be administered electronically, you could think about sort of um, methods like electronic respondent-driven sampling, um, which help even within sort of smaller population sizes, help to sort of generate population size estimates that then can be used to create weights that help to standardize the responses of your DCE such that they reflect the underlying source population from which these individuals are derived. So I think there's really a large variety of sampling strategies we could use to ensure generalizability, but I think generalizability is not always the goal of a DCE, even though that's oftentimes a goal of our research. It's not always the specific goal of the DCE.
Got it. Thank you. Okay, we have a few minutes left. I'm going to try to get through at least like maybe one more question. Another one, and I hope that this is clear enough. Have you considered using best worst scaling, aka max difference? Can you speak why or why not, and what the implications might be?
Yes, absolutely. So I didn't have an opportunity to talk about maximum difference scaling or best worst scaling in this specific presentation just because I didn't have anything there wasn't anything necessarily ready to share. It is another valuable tool in the suite of CBC methods, just like a discrete choice experiment. I think functionally, the difference between a discrete choice experiment and best worst scaling is that in a discrete choice experiment, your levels are interchangeable between attributes. And so what it is you are asking people to make forced choices of an entire product, whereas in best worst scaling, you are oftentimes not always asking people to make choices between apples and apples. So the sort of corollary I can offer to this is that in a DCE, we may be trying to understand what are specific features or um, items that drive people's preferences for a specific product like a car. So, is it a specific color, or is it a price of a car that really drives people's preferences? Whereas in best worst scaling, if we're a restaurant owner, we may only be able to offer 20 or so dishes on our menu out of a list of 100. And so we can use best worst scaling as a technique to sort of identify which 20 are going to be the most preferred. And those don't necessarily need to have sort of interchangeable levels. So, in other words, I think that if you are in a situation where the types of components of your intervention or strategy are not interchangeable necessarily, so in other words, you may be comparing apples and oranges, best worst scaling may be more appropriate than a discrete choice experiment.
Thank you. Okay, and we are just about out of time. So last quick question. Are there any opportunities that you know of for additional kind of training on these types of methods or resources that you could share?
Yes, certainly. So the University of Aberdeen in Scotland offers a very popular week-long seminar. It's usually in person in Scotland, or sometimes it's in Canada, that I think provides a nice, crash course on these different methods. There are also a very large suite of online sort of trainings you could dabble in that are free. So, for instance, Sawtooth software, which is one of the more popular choice-based conjoint method softwares, they offer a host of webinars and recorded trainings that are free to access through their YouTube channel. And then you can also always contact me if you want to learn more.
Thank you so
Advertising my services.
much. Thank you so much, Dr. Rosen. Yeah, I'm sorry we weren't able to get through all of the questions, but I'm really excited that there was so much enthusiasm here and your talk really generated a lot of interesting questions. And so hopefully those participants could or attendees could just follow up with you via email if there are questions that weren't answered today. But this was really a fantastic talk, Dr. Rosen. Thank you again so much. And thank you everyone for attending. And just a quick reminder that we'll have Our second talk next Tuesday, October 28th at 12 p.m., Dr. Maggie Price will present on using human-centered design to develop targeted implementation strategies to promote the adoption of health equity practices. So we hope to see you again. Thanks so much, everyone.